حياكم الله الشباب على الليكشر تبعنا اليوم. أكد لي مرة ثانية الصوت واضح لكم؟
واضح دكتور.
واضح دكتور.
ممتاز. طيب, the lecture is all about osteoarthritis introduction. The osteoarthritis is going to be a repeated pathology that you will be discussing throughout this block. خصوصا الفترة القادمة. You will get it from different aspects. Today we will take an overview on what's going to be the management when we're handling the osteoarthritis, right from the simple management, which is non-drug, before you use any drugs, and مرورا بالدrugs انتهاء بالsurgical management. Starting with the knowing the populations who's getting the changes is getting more as we advance in age. سنة الله في البشر. As we grow, we get some degeneration in our joints, and it goes more with the age. The higher the age, the more the expectation is gonna be with the osteoarthritis. بكل بساطة, just take it simply as wear and tear. The use of the joint depends on the usage. The wear will be more with the usage over the years, and the more the wear, the more the osteoarthritic changes will be, and will be more evident with the time. And about 60% of those patients will have some symptoms who are gonna get an osteoarthritis, and it's a common cause for people to come and see a primary care physician. It's called degeneration, and the joints, it can affect all joints in the body. A primary joint is the weight-bearing one, which is a common in our population, is the knee, and followed by the other joint, which is the hip, and almost all joints can be affected. It depends on the load as the main target on the joint affected. So it gives, the more degenerations that you get in the joint, it gives you some mechanical abnormalities with the degradation, and the cartilage itself gonna change, and the end point will be some changes around the joint, which is gonna be the articular surface with some sclerosis, subchondral cyst, and eventually will end up with bone on bone, and that will start giving more severe symptoms. So when we got a patient who has an established osteoarthritis, how can we manage those patients? And this is going to be the main objectives of our lecture today, is to look at the non-pharmacological management, and we'll go through some elements of the pharmacological management and the surgical at the end solution. So the non-pharmacological, it is always recommended, and we always educate patients how to use this to help in alleviating the patient pain. And this recommendation is based mainly on biomechanical observation that helps in modulating the load on the joints and improve the symptoms of the joint that is affected with the osteoarthritis. So the goal of the management that we hope to get through is to control the pain and the swelling around the inflamed joint from the degenerations, and minimize the disability that the patient is getting because the more symptoms there, patient will try not to use the joint, and then it will have some limitation on his daily routine, and disability will be an end point. And we hope to control the symptoms and allow patient to move, so that's going to give him a good quality of life. uh, Life is motion, so we believe in that, and without motion, then quality of life is affected. And by achieving our targets, we hope to prevent a progression of the process. And the key part of the management is the patient himself. He need to be fully aware of his disease and the consequences and the endpoint and all the elements that can help in order to install the management. It's all in the patient's hand to be able to start implementing this on daily basis. So what options do we have as a non-drug management? So we have a different group. One of them is orthosis, which is things that he can use to help the joint affected with the osteoarthritis. The insoles, this is something you can place in the foot. We'll go through it. And exercise, as well as diet and patient education, and some others we will get through. Weight loss is a very important part of the non-drug management. Obesity is strongly associated with the development of osteoarthritis, which is not surprising. The higher the weight over a joint, it will enhance overusage, and then over a time the joint will start suffering from that weight. So weight loss may produce improvement in joint pain and function. And the when it's combined with the diet and exercise, most of those patients will get a significant effect of improvement. And patient is always reporting good improvement after installing the management that way. When somebody getting an osteoarthritis, this is something bad. We shouldn't allow a rest for a patient, and in the acute attacks we shouldn't allow him more than a day, because more rest will enhance the symptoms more, and muscle condition will be atrophied, and then the problems will be prolonged, and then eventually the joint range of motion will be affected, and then it will start getting more with limitation of function, which is something we should stay away from it. We should always encourage patients not to take a rest more than a day, and should start moving the joint in order to get it back rehabilitated to the function. Physical therapy, it's a very good and important element in the non-drug management. Uh, it does its effect by improving the flexibility and strengthening of the muscle around the joint. And by getting that, we get to the improvement in function as well. So the appropriate exercise program usually designed based on the patient condition. So always the patient's gonna go through a main elements in addressing gait, strength, flexibility, uh, ability to do aerobic power, and exercise capacity. So low impact exercise to avoid excessive joint loading is always helpful, because you don't want to load on the joint that is already degenerated. So you want to reduce the high impact sport. Like, some people thinks that going upstairs when patient having osteoarthritis gonna enhance the joint functions better to get better, which is totally wrong, because when you go up the stairs you're putting more excessive load on a joint, which going to increase the joint reaction force at the articular surface that is already degenerated, which is gonna hurt that joint. But instead of doing that, you want to go with the low impact exercise, as we will talk about it. In advanced osteoarthritic changes, aquatic exercise are of a good benefit to start in those kind of cases, and it helps in improving the joint that is affected advancedly with the osteoarthritis. So there are multiple factors that should be considered when a physiotherapist receive a patient after we send the patient to go to physical therapy program with osteoarthritis. So always the physiotherapist will assess the patient joint condition. Is it inflamed? Because if it's an acute inflammation, a specific design program will be made, which is going to help reducing the inflammation gradually before loading with an active exercise. So that is an important element the physiotherapist is looking at. And the pattern of joint involvement, is it globally or on a specific area in the joint? The muscle status, how is the muscle condition? Some patients, they present really late when muscle condition is really atrophied, and that will be a main target of physiotherapist, is to try to build that muscle power back. The range of motion and regaining the ability to have a joint range of motion is a main target. And is there any limitation of medical condition? Some of those patients has some cardiac issues, some medical issues, so they could not exercise due to other causes, but they can do some limited programs. So all of those elements has to be taken into account. An all exercise program should include range of motion and isometric strengthening, so they limit the motion and build the strength of the muscle without loading on the joint itself. And the patient with an active inflammation, advanced disease, has a significant functional limitation. These interventions may be at a high level of exercise they can initially be done. So it depends on the patient condition and severity. Some of them, they couldn't do uh, high intensity uh, exercise to strengthen the muscle if they presented late. But those patients who present early, they will benefit a lot from those exercise that is gradually getting higher in intensity. A patient with the less severe disease may always sequentially go through isotonic strengthening, aerobic, and even ultimately go to recreational sport activities. The goal of the exercise program, we reduce pain and improve functions, produce production of protection of the joint at risk. This is a very common. Somebody who has a right-sided joint problem, they will always load into the left side, let's say. So that left side will take more load. Remember what we've talked about in the beginning. It's a wear and tear, it's a utilization. So the higher the utilization will increase the chance of wear and tear. So that joint at risk has to be protected by building its muscle strength and try to reduce the load on that joint by protecting it with all the modality that can be given, even in the coming part of the options. And doing that will help you prevent the disability as well. Range of motion and strengthening exercise can reduce pain and increase mobility of osteoarthritis. So the following assessment should be made prior to begin an exercise program: the passive and active range of motion, the ability to maintain gait, and stair climbing, and even the chair stands. All of this to help maintaining the balance and the ability to get to function, because eventually people has to climb stairs in order to do that for functions. So joint protection exercise, we can do that with exercise that can cause low load effect, such as swimming, bicycle, and walking are very helpful in developing good strength and protect the joint. The cardiovascular warm up, uh, followed by stretching, is recommended prior to any resistant exercise to improve the circulation and reduce the stresses on the joint. Patients should avoid stair climbing, which increase the load on the joint. People who exercise regularly are usually healthier and usually live longer. الأعمار بيد الله, but this is what statistics is showing. Those who maintain a good exercise and maintaining all the elements get longer life. And the exercise doesn't need to be really intense in order to improve the quality. An option that we may use is a trial of soft elastic heeled sport shoes and use of insole. I always recommend this to the patient when they get a sport shoe. Remember, when you're up on your feet, the weight will be always going down to the ground, and a joint reaction force will be getting back with the impact of the weight on the ground. So it will reflect back on the joint. Speaking of the joints here, like the knee joint, always when they have sport shoe, it will absorb some of that reaction force that goes back with the impact of the weight on the ground. So we encourage the patients to always have those and not to walk with barefoot حتى في البيت, because this is going to induce some changes in the joint and might induce the inflammation of the arthritic joint. Other modes in osteoarthritis, unloading the osteoarthritis, is to use the cane. العكاز بنفسه, by using it, it will help reduce the load on the affecting joint by as much as 50% on the joint, classically the hip joint. So focus with me on this exercise, on this drawing. The patient who has um, okay, so on the B1 كم واضح لكم المارك اللي أنا حاطه هذا البي هنا. This is a patient who has An advanced osteoarthritis. Advanced osteoarthritis will affect the joint and there will be a bowing of the joint. فلو انت تشوف الويت بيرنج على الجوينت، الجوينت اخذ المنظر هذا. I'm doing it يعني بشكل عنيف شوية عشان تفهموني. فالله خلقنا انه يكون عندنا biomechanical axis من منتصف الهب جوينت هنا الى السنتر اوف ذا انكل جوينت هنا. كل ما كان البوينج اعلى بالشكل هذا في حاجه هنا اسمها ليفر ارم بتكون اعلى كل ما مال للجانب. فكل ما بعد الاكسس هذا، المنطقه هذه اللي تكون منطقه التقاء الجوينت يحصل فيها وير اكثر، تستهلك اكثر. عشان كده دائما تلاقوهم الناس اللي عندهم ادفانس ني اوستيوارثرايتس دائما الميديال جوينت لاين ويرنج يحصل فيه اعلى، ويكونوا غالبا عندهم سيمتومز حتى من البدايه تبدا دائما في الميديال جوينت سيرفيس. فاللاين هذا can we help reducing it? We may apply something on the aspect هنا في lateral side حاجة اسمها insole. By putting it on the side هنا بتقلل الليفر arm هذا، نقرب أكثر للنورمال of a central pressure في المكان هذا. فبالتالي احنا نحطها دائما في ذا المكان حاجة اسمها insole. فأول ما الإنسان يحط رجله على الفوت فتكون هي تغير في شكل القدم لما تنزل مقابلة للأرض، وتقلل الليفر آرم هذا for the hope of improving هذا الليفر آرم في المكان ده، وبالتالي يخف الجوينت رياكشن في المكان هذا اللي هنا. أتمنى الصورة تكون وضحت لكم. هذا one of the non-drug management tools that we might use اللي اسمها insole. Other modality is to get a help of relief of inflamed joint. A common joint بيحصل فيه some inflammation with osteoarthritis in the carbo-metacarpal joint in the base of the thumb. We apply this brace for a short period of time to reduce the inflammation and then start the physical therapy program to get the functions back. So these braces might be of help في targeted time in a specific condition, but not for a long time, so you won't affect the function of the muscle and the condition of the muscle. Diet. The role of diet in the management of osteoarthritis is not very clear. I'm sure كثير من أفراد العائلة عندكم بيسألوكم من فترة لفترة what can we get to improve the condition of osteoarthritis. This is unfortunately not very clear. We rely on some observational study. The risk of osteoarthritis progression, it does increase threefold in patients with low vitamin D intake. So those who's deficient in vitamin D and has already established osteoarthritis, they have a higher chance of progression of a disease. Although low intake of serum level of a calcium vitamin D did not cause the risk of developing osteoarthritis. فاهمين الفكرة كيف؟ يعني مو شرط انه اذا كان هو deficient يدخل في osteoarthritis, but he has a chance if he's already getting an osteoarthritis. So, the bottom line, maintaining vitamin D supplement is indicated in patients with a high risk for osteoporosis as well. So, bottom line, yes, those who's deficient need to correct their vitamin D level. Taping, this is one of the modality that some physiotherapists are helping. The action of a muscle on a joint might be affected when the patient got a weak muscle, فيحصل drifting للmuscle classically around the knee. في عندنا, as you know from the anatomy, we have a different muscle heads acting on the knee. The vastus medialis will be the first muscle to be weak. When it's weak يحصل فيه drift للweight active force on the muscle that is attached to the knee, ويحصل فيه drifting لاتجاه actions of the muscle. So patient might present with a specific spot in the knee causing pain. هنا الفيزيوثيرابيست يجي يحط له taping, shifting the active muscle at the current time. This modality will help the patient pain and will let the patient be engaged more in the strengthening program. And that muscle that is weak, it will start regaining its strength again and will help in realigning الactive force على الجوينت. وبالتالي النيد for taping هذا حيكون غالبا short term, commonly خلال couple of weeks, and then we'll take it away because the muscle is taking over again. So this is one of the modality of the taping. If you see it, some physiotherapists are using. Heat and cold. The theory of pain is very complex. إلى أيامنا هذه وإحنا لازلنا trying to study why we get pain. What is the real pathway? What is the triggers that we get pain? So it's a huge dilemma, and theories multiple as there. So the use of heat and cold modality in improving pain nerve endings around the area of the affected side, it varies among people. So moist superficial heat raise the threshold of pain and reduce the analgesia by acting on the free nerve endings and decrease the muscle spasm. Although superficial cooling decrease the muscle spasm and increase the threshold of the pain. Ultrasound therapy, it does a specific effect في بعض الحالات. It send a deep waves to the insertion on the muscles around the joint insertion point or origin, and create a deep heat in order to enhance the connective tissue extensibility. And the potential benefit of this modality is ability to improve the muscle contracture and increase the joint range of motion. So it has no clear benefit, and it is not always recommended as a therapeutic options, but it has a specific need for a certain patient, and this is one of the modality that is always in the physical therapy departments to help patient, especially those who got some inflamed muscle from the origin or the insertion. It helps them get the recovery by utilizing this modality. مد باك ثيرابي بتشوفوها في دول كثير تستخدم، وكثير يسافروا عشان يستخدموا هذه الحاجات، وفي بعضها أصلا products that can be used at home. So this modality might improve physical conditions by improving the uh, antioxidant defensive in the serum itself and reduce the oxygen radicals and lower the inflammatory mediators around the affected joint. So we're not very clear how does this act and do the action, but this is some of the modality that can be used to alleviate pain around an arthritic joint. Acupuncture, um, it might lead to a statistical significant of improvement in pain, and this improvement is usually small and might be questionable for a clinical significance, especially in the long run. Um, it definitely going to be helpful for acute conditions. Uh, this is one of the modality as well that is used in many physical therapy departments to help the patient who present with the acute symptoms and need some support. So this is a modality that help reducing their pain. The techniques and modality that we've talked about can be used to help improving the patient's condition. And we're not saying that it's definite recommendations, but this is all our modalities that can be utilized as a non-drug management. The psychosocial evaluation is very important. Physical limitation, feeling of frustration, dependency. This is going to complicate the management of patient with osteoarthritis. Many of those patients has a significant limitation, especially with the advanced disease. This is never go without some impact on the patient's psychological condition, depression. So the psychosocial evaluation is very important, especially in advanced osteoarthritic changes. So the management depends on the patient expectation, level of the functional limitation, and the joint involved, severity, and the occupational need to help them be functional in their life, and the medical condition, comorbid condition with the patient. So the always the patient is the main player in the management. So we need to educate the patients about all those modality and the need to get it all as a lifestyle modification so he can see the effect very clear. ندخل على الجزء الآخر. What can be used as a pharmacological management? The use of acetaminophen, paracetamol, NSAIDs, COX-2 inhibitors, and opioid, all of this modality going to be of a treatment that can be offered, provide that the patient doesn't have any issue with any of them, like the NSAIDs. Some patient has allergy to NSAIDs, might have some gastric problem. NSAIDs might affect them, and some patient have even with the chronic use of the NSAID might hurt their kidneys. So always these medications should be used with caution. The safest one to be used is the acetaminophen, provide that the patient doesn't have any liver problems as well. So no medication goes without some limitation. So always those medications when it's used, we do not recommend using it for a long time. We just recommend using it through the acute attack, usually days, couple of weeks, and they need to get out of those medications. They shouldn't live on it. Unfortunately, we have a very bad cases where using medications, specifically NSAIDs, for a long time that end up hurting their kidneys and end up being on dialysis. So medications going to help only in the acute condition. The COX-2 inhibitor and typically NSAID have more problems than the paracetamol. And opioid, it has some effect, but the use of it might go on with some other problems like constipation, and we should use it for a short term only. And some of those again might overuse those medications when there will be some dependency problems. I'm sure you got many people talking about glucosamine and chondroitin sulfate components. These components is actually available in the joints, يعني naturally موجودة. فutilization of these um, are no better than placebo and the pain medications effect. This is based on multiple studies. لكن في some other contradicting studies showing some improvement, and some people may report some improvement on those patients. You never know whether it's a placebo or real. So it is considered to be one of the natural products that can be used to affect and support the joint health status. So I always let the patient make that decision. If the patient is a believer of المكملات الغذائية, what they call it, then they can get the benefit of that. Like we do not have a strong supporting evidence that these products is gonna help. So it is an option that is open to the patient to use, provide they do not have any limitations against it. The use of steroids might be of a help in acute condition. The patient who experience an exacerbation of pain and evidence of joint effusion, aspiration, and use of steroid might give you a dramatic improvement in the joint function. Unfortunately, some people might take it against the use of that steroid because they will always think that this use of a steroid enhance the degenerations of their joint, and they link this to the initial use of a steroid, which is not reality, because the joint is actually advancedly osteoarthritic, and that steroid that was used at one stage, it actually helped them get better. And then they started to see the moment the effect fade away and the arthritic joints continue to have the symptom, then they will say that it's an effect of the steroid. But definitely, the steroid use intra-articularly in the advanced osteoarthritic changes, acute exacerbation, is of a good help. And it is used only in that specific. It doesn't take us osteoarthritis away or change any of the modality. The use of hyaluronic acid injection تسمعوا فيها كثير اللي اسمها إبر الزيت. These these products inject into the knee has been approved by FDA. And these preparation can be used with a different concentration. And these studies that was made is really contradicting. There are many studies based on the use of those products to be injected in the knees to help the osteoarthritis. Meta-analysis suggests that there are biased existed in the literature that these products is used with a small or substantial placebo effect. So with utilization of that products in early osteoarthritis might be of a help, might be. We're not saying we have a strong evidence to support that, but again, this is might be of a help in the early osteoarthritic changes, but it doesn't have a proven strong evidence to support that. Now we move to the last option to treat patient with an osteoarthritis, the surgical management. The advanced degenerations, we get some changes of the joint itself, articular surface. Remember, you have a hyaline cartilage lining your joint inside. With an advanced osteoarthritis, that lining will be start will be getting through a degradation, and that degradation products leave some particles inside. So in the past, we've been doing what we call it a debridement. So the debridement for the joint with the arthroscope might help in reducing the pain, acute status, and most of those procedures were also utilizing steroid at the same time. But studies showed there is no clear benefit with that procedure, and surgeons start to move away from that option. It's not a recommendation anymore to do the arthroscopic debridement. So we are left with the other modality, the subset of individuals who have a mechanical symptoms as a result of loose bodies or meniscal cartilage or flaps that causing locking in the joint might benefit from the arthroscope. So some of the products that is causing some locking mechanical effect might be of a help in that kind of a management, which is arthroscopic knee surgery in those advanced osteoarthritis. But patient who has some limited area in the joint, classically medial joint osteoarthritis, um, the patient who has a medial osteoarthritis has a reduced joint space on the medial aspect, as you have in the slides, where we do an osteotomy and realigning the joint. Usually, those patients will have what we call it genu varus. So the leg will drift into the inward and loading the joint فاكرين السلايدز حقت الليفر arm. It will affect the patient medially, and uh, in order to reduce the effect on the joint زي الصورة هذه نعمل cut في البون and then realign that بالمنظر هذا. We make that cut and then we fix it with the plate like you have in this slide. Here, the whole alignment has been changed. This alignment now is almost biomechanically uh, zero angle, not like this where it has some curve with the genu varus. By doing this, we reduce the load on the medial aspect of the joint and putting the center of gravity within the knee rather than medial aspect of the knee. As we have more advanced osteoarthritis, the whole knee is affected, and we're left with the total knee replacement in advanced stage. Another option before we get to the total knee, if the medial aspect is only affected, we put only a half knee, which we call it unicompartmental knee unicompartmental knee replacement as an option for a selected cases only. Now, with this slides, we came up to the last part of our lecture on options on what to do with a patient who developed osteoarthritis. Any student would like to ask a question, just go ahead, take the mic, and ask a question.
السلام عليكم.
Mr.
دكتور، الجينو فيروس هي انه النيز تبعد عن بعض، صح؟ they go laterally.
لا ما تروح lateral. النيز قصدك، يس
ايوه
when you
النيز.
focus on the knees، لكن
يس.
الفيت حتروح close to each other.
ميديالي. اي تمام، شكرا.
صحيح، مظبوط.
يا دكتور عندي سؤال.
تفضل.
في الارثروسكوبيك ديبرايدمنت بس بنشيل الارتيكولار كارتلج ولا في حاجة ثانية؟
We do not take the articular cartilage. No, not at all. Actually, you shouldn't hurt the articular cartilage. You will take the uh, products that is degraded and floating within the joint. Uh, there is a part of the meniscus is being degraded and flipped that can cause a mechanical block that can cause some mechanical symptoms. So the scope going to take that part away. طبعا the patient who get this is a very limited cases. Majority of the patient, they will just have a degradation of the joint uh, and free particles within the joint. Usually those cases not recommended to use arthroscope. With the scope is being used with some reservations for a patient who got a block nowadays. لكن in the past كانت تستخدم بشكل routinely الارثروسكوبيك knee wash, and studies showed that it is not a modality that is recommended لأنه when we compared it with the sham, which is just a placebo, it showed a similar effect. So that's why it is not a modality that is recommended nowadays.
تمام.
أي سؤال آخر؟
دكتور عندي سؤال تسمح لي؟
تفضل.
دكتور دائما نسمع ب another modality of injection اللي هي ال stem cells injection، بس ما ذكرت في السلايد هنا، ف تقدر توضح لنا هي؟
جميل سؤالك، جميل سؤالك. الستيم سيلز اللي بتسمعوا فيها this is still in the lab level. The use of stem cells في الhuman is a very very limited evidence. We do not recommend that. مع الأسف كثير من السنترز اللي talking about that أغلبها commercial، عشان كده عمرك ما تشوفها في أي سنترز حكومية أو major institutes. أغلبها تلقاها مراكز عيادات صغيرة وشغلات من هذه. مع الأسف أغلبها targeted commercially و driven by commercial support. there is no evidence to support that stem cells used in osteoarthritis. طبعا في trials here and there and majority of the controlled trials اللي معمولة تلقاها show no benefit. unfortunately we're looking forward for that to be a modality to be used in the future. العلم عند الله. لكن as we talk right now, we do not hold any evidence to support the use of that. أي سؤال آخر؟ طيب أعتقد كده we reached to the end point of our lecture.